Hello, my name is Mohammad Umar Akram. I am a hospitalist at Advent Health, Orlando. Today I'm going to present an interesting case of ulcerative colitis manifesting as Fulminant Budd-Chiari Syndrome, a rare association, and its successful management with tips. Ulcerative colitis is an inflammatory disorder linked to thromboembolic events. Although its exact cause remains unclear, factors such as endothelial dysfunction and altered coagulation factors play a role. Budd-Chiari syndrome, characterized by hepatic vein thrombosis, can stem from ulcerative colitis, leading to hepatic injury. The spectrum of illness associated with Budd-Chiari syndrome can vary from an asymptomatic state to fulminant hepatic failure. This report details a case of Fulminant Budd-Chiari syndrome in a young female with ulcerative colitis. A 24-year-old female with a past medical history of ulcerative colitis presented with hematochezia and abdominal pain, accompanied by worsening confusion and altered mental status. She exhibited tachycardia but remained hemodynamically stable. Right upper quadrant tenderness was noted on examination. Lab results revealed significantly elevated LFTs with ALT and AST in thousands. Albumin was low and prothrombin time was prolonged. Extensive diagnostic workup excluded infectious and other potential etiologies. A contrast-enhanced CT revealed multiple thrombosis within peripheral hepatic veins, raising concerns about Budd-Chiari syndrome. Colon displayed diffuse thickening consistent with pancolitis. Anticoagulation with heparin was initiated at this point. A flexible sigmoidoscopy confirmed inflammation extending in a continuous and circumferential pattern from sigmoid colon to transverse colon. A biopsy wasn't performed due to patient's coagulopathy. To address fulminant Budd-Chiari syndrome, a decision was made to perform transjugular intrahepatic portosystemic shunt procedure. Following TIPS placement, portosystemic gradient improved from 10 to 2 mm of mercury. Subsequent lab tests showed significant improvement in patient's LFTs. The patient gradually improved and was discharged home in a stable condition. Top two pictures show hepatic vein thrombosis seen on CT abdomen. The bottom picture shows TIPS placement. Ulcerative colitis predisposes a patient to prothrombotic state. The exact mechanism is poorly understood, but it can be attributed to endothelial damage from inflammatory cytokines. The incidence of thrombotic events during an acute flare magnifies to 8-fold. Budd-Chiari syndrome is characterized by obstruction of hepatic veins, leading to diminished blood flow out of the liver, culminating in venous congestion. Doppler is an initial imaging modality. CT and MR angio can help delineate the exact location of the thrombus. Hepatic venography is an invasive procedure but is gold standard and is only employed if earlier studies are equivocal. With availability of advanced radiological studies, liver biopsy is rarely performed. In our case, patient met the criteria for fulminant Budd-Chiari syndrome with severe elevation of LFTs, acute liver failure, coagulopathy, and hepatic vein thrombosis. Anticoagulation initiation is crucial unless an absolute contraindication is present. TIPS should be reserved for patients who do not respond to anticoagulation and those who rapidly evolve in an acute liver failure, as in our patient. This case serves as a reminder of importance of considering Budd-Chiari syndrome as a potential complication of ulcerative colitis, particularly during acute flare-ups. Ulcerative colitis, being a chronic inflammatory disorder, can induce a prothrombotic state, thereby elevating the risk of thrombotic events. Timely placement of TIPS upon failure of anticoagulation to decompress the liver is crucial in managing the rare yet potentially life-threatening condition. Thank you so much for your time.